consider a pretty classic question in the economics of insurance. How do enrollees in an insurance plan respond to the cost sharing, the prices that they face within the plan? Policymakers, in setting the prices for Medicare Part D, were balancing this price effect, this moral hazard, against the desire to provide risk protection for the enrollees. So it's important to understand not only the budgetary implications of this moral hazard, but also if people respond to prices by cutting back on consumption, whether there are effects on health outcomes. So in Part D, we observe quite a bit of price variation, and there are some interesting quirks. Prices are nonlinear, so as you move into different coverage phases, you face changes in prices. The decision-making is potentially dynamic, so people don't buy all of their drugs on January 1st. They are making decisions throughout the year. And rational, forward-looking individuals should only really respond to their marginal end-of-year price, but if people are myopic, imperfectly forward-looking, or uncertain about their drug needs, this may not be what we see in practice. And finally, there are a bunch of different drugs with different prices. To put this in perspective, if I go to the supermarket, I can buy as many units of, say, soap as I want to at the same price. In Part D, if I'm buying prescription drugs, I face a deductible price, then my price decreases, then it increases, then it decreases again as a function of my increasing expenditure to date throughout the year. It also may be very, very difficult for people to figure out what their prices are for particular drugs in future coverage phases before they actually pay those prices. So for example, I may know that I have some gap coverage, some donut hole coverage, and pay a copay once I hit the gap. But that coverage may take the form of some generic coverage or all preferred generics and some branded coverage. So knowing that I have some coverage is not the same as knowing what the prices are going to be once I get there. So this is all very complicated. What we do is look at how consumers' consumption in Part D, consumption of prescription drugs, responds to changes in cost sharing they face between years of enrollment in a plan. And because there's a lot of inertia, people really never switch out of plans once they're enrolled in them, we can think of this as exogenous variation. So we estimate overall price elasticities by looking at behavior for people in the interior of coverage phases. We look at dynamics in price responses to see whether there's evidence of myopia. And we look for evidence of people responding to more visible price changes as evidence of price salience. So at the top of the slide here, you can see the dynamics in consumption response for, in the left panel, low spending enrollees who end the year in the initial coverage phase, and on the right panel, high spending enrollees who end the year in the donut hole. They have different dynamic incentives. So for low spending enrollees, the dotted line at the top is the percent of people in their marginal coverage phase. So as I said before, people who are perfectly forward-looking and rational should only respond to their marginal price. For low spending enrollees, they pretty much begin the year in the ICR and end the year in the ICR. And their marginal price response, the solid blue line, is pretty flat over time. For high spending enrollees, who start the year in the initial coverage phase and end the year in the donut hole, their marginal price response, their donut price response at the end of the year is more than triple their price response at the beginning of the year. So they're much more responsive to their marginal price once they actually hit it. And this is pretty strong evidence of myopia. At the bottom, I'm showing some evidence of people responding to the salience of prices. So in the bottom panel, we can see the low and high enrollees' price responses to the three coverage range prices, the deductible, ICR, and donut, and a variable that's more visible. It captures stark variation in donut hole coverage. So the donut hole covering coverage either dropping or adding an entire category. And what we see is that people respond to this more visible price over and above how they respond to the prices that pertain specifically for them. And this also happens for low spending individuals who end the year well before they would ever hit the donut hole. So this is pretty striking evidence of price salience effects. So what's the punchline? So first of all, we demonstrate that people are price sensitive in prescription drugs. This is similar to the literature. We find that people are imperfectly forward-looking. So people are much more responsive to their current prices than they are to the prices they face in the future. We also find evidence of price salience. People respond to prices that are more visible to them in addition to prices that pertain for the specific drugs they take. The overall punchline is that if we fill in the donut hole, as we're going to under the Affordable Care Act by 2020, spending is going to increase by about $120 per beneficiary on average. 26 of these dollars is going to be due to the salience effect that I mentioned before, which means it applies not just for people who hit the donut hole, but for people who never do. Finally, I want to end by saying that the welfare implications of this are not just budgetary. When we fill in the donut hole, spending is going to increase. I'm almost done. But we also have some preliminary evidence showing that price increases are associated with higher mortality, particularly for the sickest 5% of individuals. So spending is going to increase under the Affordable Care Act through closing the donut hole, but we're trading that off against potential substantial reduction in mortality.